Hi, good afternoon, everyone. The topic for today is antiarrhythmic drugs. I'll be discussing the first basic part of antiarrhythmic drugs today and the rest of the topic day after tomorrow. Okay, so let's start. Now, first of all, what are cardiac arrhythmias? Since we are talking about antiarrhythmic drugs, we need to have a little basic knowledge about cardiac arrhythmias. So, cardiac arrhythmias are basically any deviation that occurs from a normal pattern of the cardiac rhythm. So, anything that deviates the cardiac rhythm from a normal pattern is known as cardiac arrhythmia. Now, what are the causes of cardiac arrhythmia? Either they can be divided under two broad categories. Either they can be due to problems in impulse formation or due to problems in impulse conduction, or they can occur as a result of combination of both of these, right? Okay. Now, electrophysiology of the heart. So basically, our heart consists of two types of tissues. Either it is a pacemaker or conducting tissue, or it is a myocardial contractile tissue. Now, pacemaker tissue or conducting tissue, it consists of mainly SA node. Apart from this, AV node, bundle of His and Purkinje fibers, they are also a part of conductive tissue, right? Myocardial contractile tissue, it consists of atria and ventricles. So, if we take a broad idea, basically what happens first is there is impulse formation and then this impulse is conducted. Now, this impulse formation, it occurs at SA node, from where it is conducted via AV node, bundle of His, Purkinje fibers, and finally reaches the ventricles, leading to ventricular contraction. Okay. Now, let's have a look at the action potential. Basically, this action potential is of mainly the contractile tissue and Purkinje fibers, that is atria, ventricles and Purkinje fibers. So, this action potential, it starts with phase 4 and it ends with phase 4, and it has these different phases. So basically, first phase or the phase 4, it is characterized by a stable resting membrane potential of around minus 90 millivolt. After this comes the phase 0. Now during this phase, what happens is there is opening of fast sodium channels. Now since the sodium conductance, it increases and sodium it gets into the membrane. So you see this Vmax increases or this slope, it rises. Now after this, what happens during this phase 1, phase 1, it follows the phase 0. Basically here sodium channels, they get inactivated. They get inactivated and not closed. There are two different things, right? So here the sodium channels, they get inactivated. Now sodium channels are inactivated, but side by side what happens is potassium channels, they open. So as a result, potassium efflux, it starts. Now following phase 1, there is phase 2. Now basically this phase 2 or the plateau phase, it is characterized by opening of two channels. Potassium channels, they started opening here only, right? So here also they are open, and along with that calcium channels are open, right? So basically there is a balance between the calcium influx and the potassium efflux, right? You can see it here. There is a balance between the calcium influx and the potassium efflux. So this is phase 2. So after this, after phase 2 comes the phase 3. During the phase 3, what happens is the calcium channels, they close and there is only potassium efflux. Now after the phase 3, potassium channels, they slowly start closing and phase 4 comes. Now this phase 4, phase 4 is basically maintained by sodium potassium pump, right? Rectifier potassium channels or the potassium channels that were working here have no role here, right? This resting membrane potential, it is basically maintained by sodium potassium pump, right? So there are like 5 phases, beginning and ending with 4. Here sodium channels open, here sodium channels inactivate, potassium channels open, potassium channels, they stay open, potassium efflux is happening, and calcium influx is also happening, a balance. And during the phase 3, calcium channels they close, only potassium channels are open, and potassium efflux is continuously happening. By the end of this phase 3, potassium channels they also start closing slowly, and ultimately resting membrane potential of minus 90 millivolt is achieved. Okay. So whatever I've told you, I've described it in this slide. Phase 4, resting membrane potential around minus 90 millivolt. It is also known as diastolic depolarization. Phase 0, this is known as rapid depolarization phase. It is due to the opening of fast sodium channels. Phase 1, early or partial repolarization. This is because the voltage gated sodium channels they inactivate, potassium channels they open. Phase 2 or the plateau phase, balance between the inward movement of L type of calcium channels and outward movement of potassium channels. Phase 3, calcium channels close while the potassium channels they are still open, and potassium efflux it continuously happens through them, right? And this is all followed by phase 4 again. Now let's talk about the refractory period. Now this refractory period basically it depends upon the state of the sodium channels. See, if you have a look at this slide, basically you have to understand that this refractory period, this is absolutely refractory period, or it is also known as effective refractory period, right? Absolute refractory period and relative refractory period, they are the part of effective refractory period. Now this refractory period it basically depends upon the state of the sodium channels, right? Here the sodium channels are open in phase 0. In phase 1 they are inactivated, right? And in phase 3 they are what? Closed. So in order to open sodium channels, basically they have to be in closed state, right? Now why do we need to open the sodium channels? We need to open the sodium channels for the next action potential, right? So during absolute refractory period, basically what happens is sodium channels are basically here they are open, here they are inactivated, right? And during relative refractory period, what happens is sodium channels are in two states. They are either in inactivated state or closed state. Now the sodium channels that are closed, they can be opened if we give a stimulus that is much more than the normal stimulus. Then we can overcome this part, relative refractory period, and we can stimulate the cell for the next action potential. But during absolute refractory period, when the sodium channels are inactivated, right, they cannot be stimulated. No matter what is the strength of the stimulus that we give, they cannot be stimulated for giving the next action potential, right? So basically during the absolute refractory period, sodium channels are inactivated, they will not close, and hence they will not open. During relative refractory period, some of the sodium channels they are closed, some are inactivated. Those that are closed, they can be opened, and as a result, if we give a high strength stimulus, another action potential it can be produced, right? So if we have to define like what is the duration of absolute refractory period, or what is the duration of relative refractory period, so basically absolute refractory period it lasts from firing level, that is if you see here, this is basically the firing level, right? When this depolarization process it starts, right? After the threshold is achieved, after that we call it firing level. From firing level till 1/3 of the phase 3 is completed, right? So this is basically the absolute refractory period. During this period, no matter what is the strength of the stimulus, another action potential will not be produced. And relative refractory period, its duration is from later 2/3 of the phase 2 to the start of the phase 3. If we give a stimulus of high strength here, then we can achieve another action potential, right? So this diagram also tells the same thing about the absolute refractory period and the relative refractory period, right? So absolute refractory period from phase 0 till 1/3 of completion of the phase 3, and relative refractory period lower 2/3 of the phase 3 till the phase 4, right? Okay, now let's have a look at the action potential of the nodal tissue. We have already discussed the action potential of the atria and the ventricles in the previous 2-3 slides. So, see, there is a difference between the action potential of the nodal tissue when it is compared to that of the contractile tissue. So, first of all, there are only 3 phases. Uh, like the action potential of the atria and the ventricle, it also begins and ends with the phase 4, but here this phase 4 is different. If you notice this, see, this phase 4, it is a flat line, whereas here it is a slope, right? So basically what happens is that phase 4 in contractile tissue, it was maintained by sodium potassium pump, right? Here this phase 4 is like a slope because of funny channels. Now what happens is, because of these funny channels, there is continuous influx of calcium and sodium. So as a result, what happens is, there is this slope and the resting membrane potential is not stable. It is around minus 55 to minus 60 millivolt. Action potential in contractile tissue, it was very much stable, but here, since these channels, these leaky channels, they remain open throughout, so here this resting membrane potential is never stable. So after this, what happens is, there comes the phase 0. Now phase 0 is characterized by opening of the calcium channels. As a result, what happens is calcium influx, it takes place. This is followed by phase 3. During phase 3, what happens is potassium channels, they open, potassium efflux occurs. Now this phase 3, it is followed by phase 4 of the next action potential. Right. Now this phase 4, as I've told earlier, this phase 4 occurs as a result of the opening of the leaky channels, right? So whatever I've told you, this is the written or a more descriptive form of that. So initially phase 4, resting membrane potential, it is unsteady, it is minus 55 to minus 60 millivolt, and it occurs as a result of the leaky channels, which lead to sodium and calcium influx. Phase 0, L type of calcium channels, they open, calcium influx occurs. Phase 3, potassium channels, they open and closing of calcium channels occurs. So ultimately what happens is potassium efflux occurs. Now once the membrane potential, it reaches minus 55 to minus, sorry, there's a mistyping here, it's minus 60 millivolt. Sodium and calcium influx through the leaky channels, it starts. So as a result, what happens is phase 4 of the next cycle, it begins, right? Okay. Now arrhythmogenesis, how the arrhythmias happen, what are the factors that precipitate the arrhythmias, or problems in impulse generation, impulse conduction, or both. So factors that can precipitate arrhythmia are ischemia, hypoxia, changes in pH, electrolyte imbalance, any autonomic influence, or overstretching or physical stretching of the cardiac fibers. So as I've discussed earlier, arrhythmias, they can occur either from problem of impulse generation or impulse conduction, or both. So if we now we'll be discussing the mechanism of arrhythmias in a little bit of detail. So first of all, what are the problems in the impulse formation? Either there can be automatic activity or triggered activity, and when it comes to impulse conduction, there can be re-entry or conduction block. Here please note that re-entry phenomena is a much more common phenomena as compared to that of conduction block, right? So now we'll be discussing these topics in a little bit of detail. So first of all, automatic activity. Now automatic activity, it may be because of increased vagal activity, or maybe due to acceleration of the pacemaker discharge. Now increased vagal activity, what happens is that it can either slow down or stop the sinus rhythm. By sinus rhythm we mean normal rhythm, right? So as a result, what happens is, if the vagal activity increases, what happens is patient might have bradycardia, patient might have arrest, patient might have AV block. So as a result, in these patients, when the vagal activity is increased, we give atropine, right? In order to increase the sinus rhythm, we will give atropine. Secondly, acceleration of the pacemaker discharge by increasing the slope of phase 4. So what we can do is we can increase the slope of phase 4 by giving drugs such as beta agonists, hypokalemia, ischemia, etc. Please note one point that any changes in the potassium, serum potassium levels, heart is very sensitive to that, and specifically our nodal tissue, conductive tissue, it is very sensitive to any changes in the serum potassium levels, right? So here you can see that because of hypokalemia there is acceleration of pacemaker discharge, right? So as a result the slope of phase 4 it increases. Now, another reason could be the ectopic pacemaker activity. It can be present either in atria, ventricles, and Purkinje fibers. Because of ischemia, there will be sympathetic activation. As a result, arrhythmia might occur. Like I've discussed previously, hypokalemia is also an important cause when it comes to ectopic pacemaker activity. Now, after this, let's discuss triggered activity or after depolarization. First of all, a few general points are, regarding triggered activity or after depolarization. First of all, it does not arise spontaneously. Secondly, its initiation. It depends upon the previous depolarization, after depolarization. So you have to understand that after depolarization occur only when depolarization has happened or when an action potential is already present, right? It cannot occur spontaneously. I'll be showing you a diagram, so from that you'll be able to understand it better. So there are two types of after depolarization. It can be either early after depolarization or delayed after depolarization, right? So okay. Now, what happens in early after depolarization? The key abnormality in the early after depolarization is prolongation of the action potential, and phase 3 repolarization is interrupted. Okay, so I'll show you a diagram. See, basically what is happening here is, if you have a look at the duration of the action potential, this blue line is basically early after depolarization. See, the duration of the action potential, it has increased. Secondly, you see the phase 3, it has been extended. So basically this is early after depolarization, and you can see that it is not spontaneous, right? For its presence, for both early and delayed after depolarization, action potential should already be present. So basically these depolarizations are, they happen after the normal depolarization that occurs, right? So early after depolarization, and this is late after depolarization, right? Okay. Now, early after depolarization, it is seen in cases of bradycardia, long QT interval, which might be due to quinidine, sotalol, amiodarone, etc. Also, it might lead to torsade de pointes, which is a lethal arrhythmia, as we all know. Now, in cases of early after depolarization, what we can do is we can increase the heart rate pacing, we can give magnesium, and we can give isoprenaline, right? So, delayed after depolarization now. Basically, it is also a secondary depolarization that occurs early in diastolic phase after full repolarization is achieved. So here, basically what happens, by full repolarization, we mean that phase 3 has completed, right? It can reach to a threshold potential and give rise to premature depolarization. It occurs due to calcium overload. There is a specific reason for delayed after depolarization. It occurs due to calcium overload. It can cause coupled extrasystole or ventricular arrhythmias. So, if you have a look at this diagram, you can see that phase 3 has completed. So, basically, because of calcium influx, this threshold level is achieved, and after this, there is a depolarization. So, this depolarization is known as delayed after depolarization. Okay. Now, delayed after depolarizations, they are usually seen in patients with hyperkalemia, hypercalcemia, digitalis toxicity, adverse stress, or in patients of MI. So for these patients, we usually give verapamil and quinidine by increasing, they act by increasing the threshold potential. So basically, if the threshold potential here is increased, then this calcium influx, it will not be able to stimulate, it will not be able to stimulate the cell enough for another action potential. So by increasing the threshold potential, we are preventing the delayed action potential from happening. Okay. Now, what are the problems that might occur in impulse conduction? Well, two things can happen. First of all, there can be simple AV block, right? It can be partial or it can be complete. So, for this, treatment is simply atropine, right? But a more common defect that we see is usually a re-entry phenomena. Now basically during re-entry phenomena, what happens is a impulse, it re-enters and excites the heart over and over. Basically it forms a loop like situation, or it is also known as circus movement, right? It may occur within or near near the AV node, or it may involve the atria. When it involves the atria, it is called as supraventricular arrhythmias. Wherein it involves the ventricles, it is known as ventricular arrhythmias. In WPW syndrome, that is Wolff-Parkinson-Wolff syndrome, it is due to re-entry involving an anatomical accessory pathway, right? There is basically an anatomical pathway because of which WPW syndrome it occurs, right? So I'll be showing you a diagram. I think from that it will be clearer to you. Okay, so okay. So for basically for re-entry to occur, there are certain prerequisites that should be present. Otherwise, re-entry phenomena will not be possible. So first of all, there should be a unidirectional block to the flow of the stimulus, right? So as a result, if there is a unidirectional block, you see this diagram, see, if there is a unidirectional, see, only one side is blocked. There is block to anterograde transmission, but there is no block to retrograde transmission, okay? Stimulus cannot travel this way, but yes, retrograde transmission, it is possible, right? So secondly, apart from this, this retrograde transmission to occur, only it can occur if the tissue is excitable. That is the refractory period, it is less than that of the conduction time of the stimulus. So if you see here, for this retrograde impulse to conduct, this tissue basically the refractory period of this tissue, it should be less than that of the conduction time, so that when the stimulus reaches here, the tissue is not in its refractory period. Otherwise it will not be able to stimulate it and the stimulus will die here. See, so if you see here, basically what is happening is here anterograde transmission of the stimulus is blocked. Retrograde transmission is possible because the refractory period of this particular part of the tissue, it is less than that of the conduction time. So by the time the stimulus it reaches here for retrograde stimulus transmission, this part of the tissue, it has basically crossed its refractory period and it is not refractory anymore. So as a result, what happens is a circus movement is formed, right? Circus movement or re-entry, this is formed, right? So like I've told earlier, impulse, it will keep on moving in a loop, exciting the tissue over and over. Now re-entry can cause any type of dysrhythmias and it can be abolished by producing a bidirectional block. For this bidirectional block, we usually give sodium channel blockers and calcium channel blockers. So see, if we give a bidirectional block, anterograde block as well as a retrograde block, so there will be no chance of this loop formation, right? So we give sodium channel blockers and calcium channel blockers. Now classification of the drugs or classification of the antiarrhythmic drugs, basically this classification is based on electrophysiological effects and it was given by Vaughan Williams. There are 4 classes of antiarrhythmic drugs. First of all, class 1. Basically, no matter what subtype of class 1 antiarrhythmic drugs is there, one common thing is that they are all sodium channel blockers. Now, since they are blocking the sodium channels, basically what happens is the slope of phase 0, it decreases, or we can say that Vmax of the tissue decreases, and with fast response action potential, right? So if we go to the subtypes of class 1, class 1A, it consists of quinidine, disopyramide, procainamide. They decrease the Vmax. Along with that, they increase the action potential duration because of potassium channel blockage. So basically, class 1A, it consists of sodium channel blockage, and it also consists of potassium channel blockage, right? Now class 1B. Class 1B consists of lignocaine, maxilitine, phenytoin, tokainide. They have less effect on normal rates on Vmax, and in normal tissue, it does not affect the normal sinus rhythm. Vmax is decreased, and action potential duration, it might or it might not decrease, right? So basically these drugs, they can be safely given in patients with normal sinus rhythm, as they do not affect normal sinus rhythm, right? They will only decrease the Vmax. Effect on action potential duration is plus minus, right? Now class 1C. Class 1C consists of flecainide, encainide, moricizine, propafenone, etc. They absolutely decrease the Vmax, right, at the normal rates in normal tissues, and they have minimal effects on action potential duration. So basically here what is happening, if we give these drugs even in patients who are normal, who have normal sinus rhythm, they will decrease the Vmax, or they will affect the phase 0, and they have minimal effects on action potential duration. Now coming up to the class 2 blockers. Class 2 blockers basically consists of beta blockers like propranolol, sotalol and asmolol. What they do is that they decrease the SA nodal activity. They increase the AV nodal refractory period, and ultimately they decrease the nodal conduction. So first of all, they have kind of dampened SA node. Apart from that, AV nodal tract, they have increased the refractory period of that. So overall what will happen is the impulse conduction, it will reduce, right? Now class 3 antiarrhythmics. Class 3 antiarrhythmics are basically potassium channels. For example, amiodarone, bretailium, sotalol, ibutylide, dronedron. So basically what will happen is these potassium channel blockers, they will do what? They will increase the action potential duration by increasing the phase 3, right? Class 4, they are the calcium channel blockers like verapamil and diltiazem. What do? They decrease the conduction velocity and increase the refractoriness in the tissues with slow response action potential, right? So basically velocity of conduction and refractoriness of the tissues, it is increased. Conduction velocity is decreased and refractoriness is increased, right? So there are certain drugs that are not classified under Vaughan-Williams classification. For example, atropine given in patients of sinus bradycardia, adrenaline given in patients of cardiac arrest, isoprenaline for heart block, digoxin for atrial fibrillation and flutter, adenosine, which is drug of choice for PSVT, magnesium sulfate, which is given in patients with ventricular fibrillation and digoxin induced tachycardia. So all these drugs, they do not come under Vaughan-Williams classification, but yes, they are used in patients of arrhythmias. Okay, now there is this another classification which is based on the site of the action of the drugs. So basically drugs, they can act directly on the AV node, or they can act on the ventricles. Drugs acting on AV node are adenosine, propranolol, verapamil and digitalis, while drugs acting on ventricles usually belong to class 1B, that is lignocaine and maxilitine. Now atrial and ventricular, there are certain drugs that act on both atria and ventricles. For example, if we go to category 1A, quinidine and disopyramide. From 1C, flecainide, and from 3, type 3, it comes, type 3 is amiodarone and sotalol. Now, let's discuss some of the important drugs in details. First of all, we'll be discussing class 1A drugs. Let's start with quinidine. Now, quinidine, as we all know, it's a 1A, it belongs to class 1A. So basically what it does is, it inhibits sodium channels and it inhibits potassium channels. Along with this, there is also an alpha blocking effect and a vagolytic effect, right? So as a result, the quinidine, it will produce bradycardia. So due to sodium and potassium channel blockage, quinidine, it decreases the excitability of the myocardium. It decreases the conduction of the tissue. It increases the refractory period in most of the tissues, and it decreases the atomicity of the ectopic pacemaker tissue. So, for example, say if a patient is having hypokalemia, we can give that patient quinidine because it will decrease the atomicity of the ectopic pacemaker. Now, because of the potassium channel blockage, QT interval, it will be prolonged. Now, coming to the vagolytic effect of the quinidine. Now, due to its antivagal effect, what it does is it increases the effective refractory period of the atrial muscle and decreases the atrial rate, right? So, because of these two specific reasons, this vagolytic effect is specifically useful in atrial flutter and atrial fibrillation, right? Also, it increases the AV conduction, leading to paradoxical tachycardia. Now, this is a side effect that quinidine, it might lead to paradoxical tachycardia because of increased AV conduction. Now, because of alpha blocking effect, hypotension and tachycardia, they might occur, right? This is specifically after IV administration, right? Hypotension and tachycardia, they might occur. On skeletal muscles, there will be decrease in tone, and specifically this effect is seen in patients with myasthenia gravis, right? Now, what are the uses of quinidine? Like I've discussed earlier, specifically due to its vagolytic effect, quinidine, it is especially useful in patients with atrial flutter and fibrillation. Secondly, for prevention of recurrence of ventricular tachycardia and fibrillation. So it is used for both treatment and treatment of atrial fibrillation and prevention of ventricular fibrillation. Now, what are the adverse effects? Adverse effects are diarrhea, because of which hypokalemia might occur. Idiosyncratic reaction might occur, synchronism, hemolytic anemia, cardiotoxicity, myocardial depression, dryness of mouth, urine retention. These are some of the other adverse effects that are commonly associated with quinidine. Now, the second drug from the same class is procainamide. Basically, procainamide, it is a procaine derivative. Its actions are similar to that of quinidine. It has shorter duration of action and it has a lesser vagolytic effect as compared to that of quinidine. Hypersensitivity reactions, they are very common with procainamide, and this is the reason that its use is limited. Also, it can also cause lupus erythematosus. The major metabolite N-acetyl procainamide, that is obtained from procainamide, it has class 3 properties. Okay. Now, the next drug from the same category is disopyramide. Disopyramide, basically it is used due to the side effects of quinidine and procainamide. Disopyramide, it is used an alternative to both. It has anticholinergic effects. Adverse effects include myocardial depression, dry mouth, blurring of vision, urinary retention, etc. And disopyramide, it should be avoided in patients with bilateral hypertrophic prostate and glaucoma, right? So in patients with prostatic hypertrophy and in patients with glaucoma, we are not supposed to give disopyramide because of its anticholinergic effects. Secondly, due to its renal metabolism, dose of disopyramide, it should be decreased in patients with renal impairment. Now, class 1B drugs. Class 1B drugs, they consist of mainly 4 drugs: lignocaine, phenytoin, mexiletine, and tokenite. Now let's discuss each of these drugs in detail. So if you have a look at the class 1 drugs, basically all of them, they were doing what? They were blocking the sodium channels. Now as a result, the slope or the Vmax of action potential is decreased, right? Secondly, what 1b drugs are doing, basically they are shortening the repolarization. Now as a result, what is happening is action potential duration it is decreasing, right? Or we can also say that this refractory period or effective refractory period, it is decreasing. Now first of all, coming up to lignocaine. Lignocaine basically, as we all know, is a local anesthetic. It blocks the sodium channel like all class 1 drugs. It is used in patients of ventricular arrhythmia, especially in those who have ventricular arrhythmias that are complicated by myocardial infarction. Now, because of sodium channel blocking effect, what happens is, first of all, it will have antiarrhythmic effect. Second, decreased excitability. Third, decreased conduction and increased refractory period in cardiac tissue with large action potential duration. Example, Purkinje fibers and in ventricular muscle fibers. Now, SA node, AV node and atrial muscles, they are unaffected by lignocaine. Exact reason is not known, but yes, SA node, AV node and atrial muscles, they are not affected by lignocaine. Now, lignocaine, it exclusively acts on the sodium channels. It blocks it in open as well as in inactivated state. So as I've told earlier, like phase 0, sodium channels are open. Phase 1, sodium channels are inactivated. So basically lignocaine will act on two phases. First is phase 0, when the sodium channels are open, and secondly phase 1, when sodium channels are inactivated. Blocking of the sodium channels is use dependent, right? More frequent activation, greater is the degree of the block. And as a result, large number of sodium channels are blocked in Purkinje fibers, ventricular muscle fibers and in ischemic areas, right? So in normal tissues during diastole, most of the sodium channels, they become drug free as lignocaine, it dissociates fast. So we know that the half life of lignocaine is very short, and on the top of that, in normal tissue during diastole, most of the sodium channels, they become drug free due to fast dissociation of the lignocaine. Lignocaine, it exerts greater effect in rapidly driven tissue or depolarized tissue and selectively suppresses the arrhythmic cells. So if we give lignocaine to a normal patient, nothing will happen. But if we give lignocaine to a patient who has arrhythmias, it will exert much greater effect, right? Now, pharmacokinetics of lignocaine. First of all, it has a short T half-life. Secondly, it is unsuitable for oral administration. It has high first pass metabolism. That is the reason we don't give it orally. Secondly, it is supposed to be used by either IV route or occasionally by IM route. It is metabolized in liver and blood. It is metabolized in liver and is blood flow dependent. In congestive heart failure and liver disease, the dose should be decreased because metabolism occurs in liver, so dose should be decreased. Now, decreased liver blood flow occurring as a result of beta blockers can cause lignocaine toxicity. So in this case, when liver blood flow to the liver is decreased because of any reason, lignocaine dose should be decreased. Otherwise, lignocaine toxicity might occur. Secondly, if the patient is already on cimetidine, then also we need to reduce the dose of lignocaine. Otherwise, lignocaine toxicity might happen as cimetidine, it is an enzyme inhibitor. Okay, usually lignocaine is well tolerated unless we give like a very rapid infusion in patients with significant cardiac failure. Extra cardiac side effects might be dizziness, paresthesias and numbness. Now, precautions. Uh, what are the precautions that we are supposed to take with lignocaine? Adverse effects are uncommon with lignocaine unless we are giving it very rapidly and there is a significant heart failure. This might lead to bradycardia, hypotension and AV block. So all the patients who already have bradycardia, hypotension and AV block, lignocaine should be given very cautiously. Okay. Now, one good thing about lignocaine is that it minimally interferes with the electrical activity of the normal tissue. Also, lignocaine is very effective in ventricular arrhythmias due to digoxin and MI. Right? So, advantages. What are the advantages of giving lignocaine? First of all, quick onset of effect. Secondly, no effect on AV conduction. Third, least effect on contractility and heart rate. No autonomic effects have been seen with lignocaine. Toxic effects. They can be corrected by decreasing the infusion rate. Right? Now, phenytoin. Phenytoin is basically an anti-epileptic drug. It is reserved only to terminate digitalis-induced tachyarrhythmias as it does not aggravate AV block and does not produce hypotension. So basically, phenytoin is reserved in patients which are having tachyarrhythmias due to digitalis. Second is mexiletine. Basically, it is an oral analog of lignocaine but with no first pass metabolism in liver. It is preferred for chronic treatment of ventricular arrhythmias that are associated with previous MI. But the side effects of mexiletine is basically it can also cause AV block, hypotension and bradycardia. Being an analog of lignocaine, the only difference is that it has no first pass metabolism and it can be given by oral route. Now tokenide. Tokenide is structurally similar to lignocaine. Tokenide is structurally similar to lignocaine but can be administered orally like mexiletine. Serious non-cardiac side effects like agranulocytosis, thrombocytopenia, pulmonary fibrosis have limited its use. It is not used these days. Now class 1C drugs. Now class 1C consists of lecanemide, encanemide, propafenone and morphine. These drugs are reserved for patients with life-threatening refractory ventricular arrhythmias who do not have coronary artery disease. These drugs are highly pro-arrhythmogenic even when normal doses are administered. So as a result, these drugs are reserved for refractory patients, right, who are not responding to other drugs. Only in those patients these drugs are given. Apart from being pro-arrhythmogenic and these drugs have other adverse effects like visual disturbances, nausea, headache, dizziness, etc. Now, if you have a look at the action potential, changes in action potential with 1C drugs, you can see that first of all, because of sodium channel blockage, like class 1 drugs, change in slope, and here you can see that there is no much change in the repolarization right? So this is how the changes in action potential looks with 1C drugs. Okay, I think I'll be covering the next part starting from the class 2 drugs in the next lecture, that is day after tomorrow. If you have any queries or any problems, you can mail me your questions and queries. I'll be happy to answer them. Thank you.